Thank you so much. Good evening, good morning, good afternoon, everyone. It is my pleasure to be chairing and also facilitating our webinar today, Centering Care in the Care Economy. Thank you so much for joining us. My name is Shelene Gomes. I am Dr. Shelene Gomes. I am a social anthropologist based at the University of the West Indies St. Augustine campus in Trinidad and Tobago. And in collaboration with the University of Cape Town and all of these other brilliant speakers you'll hear today, we would like to have some discussion and presentation on the care economy. So I'm going to do a short introduction, and then we will have the presentations, and then we will have our question and answer and our discussion session. So to introduce some key points around the care economy, care work, both paid and unpaid, keeps society going. Caring for younger persons, caring for older persons, and domestic work are essential to economic production and social reproduction. It is the work that keeps society going, but it is often work that is less than visible. It is taken for granted, often low-waged and low-status work. Often, we do not think of care as work. We may consider these labors to be natural or voluntary or duty, depending on our cultural context, but it is labor that is expended, and it is this labor upon which economies and societies depend. So women typically do 3 times more unwaged care work than men globally, for example. And this is according to a report from the International Labour Organization. I'd also like to point out that quantification is not the only indication of value, but if we were to quantify the value of unpaid care work and domestic work as well, the ILO estimates that this would amount to almost 11 trillion US dollars globally. So undervaluing care work has considerable economic, financial, and psychosocial implications for care providers, families, and states. And this is precisely what our presenters will talk about from the different perspectives of caring for older persons, caring for younger persons, and the kinds of labors and the cultural contexts that are entangled in all of these kinds of work. The speakers today approach care from various disciplinary, policy, and applied perspectives in the Caribbean and South Africa to share research findings, insights, and policy recommendations around these labors. In this multi-sectoral, cross-disciplinary dialogue, speakers present diversities as well as similar patterns around the centrality of care in social reproduction and in imagining more equitable lifeways for the future. Our transatlantic dialogue today also demonstrates that across the different geographies, care remains essential. In recognition of the UN International Day of Care and Support, which is today, the 29th of October, I would also like to emphasize the important role of the United Nations agencies, such as the critical work of the UN Reliefs and Works Agency, for example, in humanitarian assistance, because this is also ongoing institutional care work. And so I would like to introduce all our speakers today together, and then I will go through a bit of housekeeping and then hand over the floor. So our agenda today will be all the presentations, as I mentioned, and then we will have some time for open discussion and question and answers. So I'm honored and pleased to introduce our speakers today. First, Professor Ameeta Jaga and Professor Fiona Ross will speak about the Motherload project in Cape Town. Professor Ameeta Jaga leads this project, the Motherload project in Cape Town, South Africa. And in the organizational psychology section of the School of Management Studies within the Faculty of Commerce at the University of Cape Town, Professor Jaga is also the Deputy Dean for Transformation and Inclusion. As a work family scholar, Professor Jaga draws upon matters of culture and gender to navigate the work-family interface. Her work questions the context in which we find ourselves fulfilling these life roles, reflecting on her own trajectory. And she uses the question, does context matter, to provoke assumptions, values, and beliefs about locally relevant yet globally important workplace issues, which give impetus to the context of her sensitive teaching philosophy and current research foci on managing the work-family nexus of a growing and diverse workforce. So welcome, Professor Jaga. I'm going to go also into introducing Professor Fiona Ross at this time. Professor Ross is a National Research Foundation rated Professor of Anthropology at the University of Cape Town as well, and a Fellow of the University. A researcher in the Motherload project, Professor Ross's work is concerned with formations of social life in apartheid's aftermath. Her interests span a variety of subfields in anthropology, including urban, medical, and linguistic anthropology, anthropological theory, and critical ethnography. Her current research, The First 1,000 Days, which I've also heard her present, is supported by an A.W. Mellon Chair, and it explores how life is made social and how contemporary knowledge formations are mobilized in defense of well-being. So welcome, Professor Ross and Professor Jaga from Cape Town. I'm going to introduce our two other speakers, Dr. Bephyer Parey first. And Dr. Bephyer Parey is a junior research fellow at the Sir Arthur Lewis Institute of Social and Economic Studies, SOLISES, at the University of the West Indies St. Augustine campus here in Trinidad and Tobago. She chairs the Disability Studies Research Cluster, which also works with the Equal Opportunity Commission in Trinidad and Tobago. Dr. Parey was a PhD student at the SOLISES, and after completing her PhD in social policy, she then joined SOLISES as staff. And Dr. Parey conducts mixed methods research into poverty and disabilities to provide policy recommendations for life course-oriented social inclusion. Our next speaker is Dr. Hyacinth Blake. Dr. Hyacinth Orchid Blake has attained a PhD in sociology in 2020 from the University of Sheffield in the UK on the research Family Care for Frail Older Persons, Social Policy Implications for Trinidad and Tobago. And prior to this, Dr. Blake successfully completed the MSc in Sociology at the University of West Indies at our Mona campus in Jamaica, where her thesis focused on humanization of community homes for older persons in Trinidad. Dr. Blake is a results-focused professional with 9 years of experience as a senior adjunct lecturer and over 16 years experience in social planning, research, and policy development in the public sector. Her experience includes serving as director of the Division of Aging for Trinidad and Tobago, and the director of the Social Investigations Division in the Ministry of Social Development and Family Services as well in Trinidad and Tobago. And she has also represented the state as part of in-person delegations to high-level international social development fora in South America, in North America, in the Middle East, the Gulf, and Europe as well. And so, as you can see from our speakers today, we'll be thinking about care and this essential work of care in terms of caring for the older persons, caring for younger persons, but also the centrality of care across not only academic disciplines, but also across sectors. This is work that is essential to the reproduction of life. And so I'd like to invite Professor Jaga and Professor Ross to lead us off. The floor is yours.
Thank you so much. I'm going to share my screen. Oh, sorry. Apologies for that. Okay, can you see my screen now?
Yeah.
Okay, great. Thank you for that beautiful introduction. And yeah, Fiona and I are very honored to be sharing some insights about our Motherload project with you on International Day of Care and Support. Our project, I'm just going to introduce and give you some background in how it came about. It was actually conceptualized during COVID, and where we had seen some quantitative econometric data that was pointing to how mothers had lost the majority of jobs. In South Africa, of the 3 million jobs, women had lost 2 million, and of those, many of them were mothers in precarious work. And it pointed to multiple vulnerabilities of hunger, of mental health, and we were interested in understanding how these actually intersected in multiple different ways and at the different layers. And so from that, we wanted to understand the nuance and the complexity that went beyond sort of the quantitative numbers, and really center the mothers' voices in this project. So to take a very sort of grounded approach in our Southern context, and to ensure that we centered these mothers who are living the realities, because some past research had shown that when policies are developed, they tend to have a middle class bias, and it then doesn't reach the citizens who need to benefit the most from these policies. So that's a little bit of a background to it. So in terms of our questions, we really wanted to understand what were these intersecting vulnerabilities. But there was also a how to this. So how the how was really around how we ensured that care was inserted into how we also worked with these mothers. So we brought them together and really said to them that they are the experts, that they are our co-researchers, that we can't do this work without them, that it is really that they really had the knowledge that we needed to try and make a difference. And so we looked at using a diversity of methodologies in terms of both arts-based methodologies, where mothers could, for example, draw journeys of their motherload, of their motherhood, using sort of hard beans as the difficult parts, but also in terms of like sprinkles, colorful sprinkles for the brighter moments in their life, and then to talk through these journeys on what it meant for them from the time that they heard that they had become a mum to where they were today with us. And the reason for this was really to ensure that they had a space to be able to tell stories without the pressure of sort of trying to deliver it in an academic way, or in a way that they felt they had to articulate themselves in a language, in a verbal language, but rather to be able to express it creatively. And so some very powerful stories came from that, and we tried to map what was coming out at very different levels. So for example, this tree was around, what is on the surface level of the struggles and of some of their concerns, but what were the deeper roots that were underpinning what they were experiencing. And so really want to try and center decolonial Southern feminism, and used photo voice together with that. And so we asked the mums to give us, to go and take photographs of 3 aspects of their life: their strengths, their struggles, and their needs. And each mum went and took photographs that they could tell a visual story to tell us what was going on in these 3 areas. And we wanted to ensure that their strengths were also visibilized, because we didn't want to reduce the women to only their struggles and their needs, but to also show that they had strengths. However, after going through the exercise, what came out is that the mothers felt their strengths were often born out of their struggles, and often, media portrays women and mothers as strong, but they said they're tired of being strong because so many other levels at, you know, community level, state level, were failing them. And so these strengths were often born out of their struggles. But for example, like the rocks portrayed persistence of, you know, just continuing to mother despite the adversity they faced. But also their strengths were in being a mother, being able to nourish a child through breast milk, being able to educate a child and send them to school, do homework with them. They often saw education as a way out of poverty or as an opportunity out of poverty. Many associated their strengths with sort of through plants. And one mother shared about her C-section, and that, you know, that depicted a particular strength. We then asked the mums about their struggles. And so mums highlighted, I'm going to give you a brief overview, and then I'm going to go into 3 deeper stories to share with you. So a lot of the struggles were around poor infrastructure, poor housing, inadequate housing, communal toilets that weren't serviced, and that was linked to, you know, just it was linked to sort of the corruption in the area, where the trucks that were meant to come and clean were often required to pay a protection fee by gangs. The mothers had to do a lot of manual labor around cleaning, washing of clothes, which is often difficult in the winter months. There was a struggle to find just a space for recreation. There were no recreational parks in the area. And if they were often gangs that had taken over them. And then it was just a struggle for mothers to almost hold mothering with anything else. If a mother wanted to try and study, or if a mother wanted to try and find a job, it was really difficult to hold these multiple roles together. And so I want to just give you some a deeper insight into 3 pictures that the mums took that told really moving stories around their mothering. So, for example, a mother captured through words at her child's school, there was the staircase that is intended to be motivational, but actually what it meant for her was that it sent a signal to say that mothers are always meant to be patient and attentive and committed, that there's this sort of aspirational set of attributes that that is associated with being a good mother. But when mothering in poverty, it's almost impossible to be able to attain these attributes, but also meet all the daily material and social needs of the child, that it was almost impossible to do all of that, because in their context of poverty, it was just so hard, and this exacerbated their mental health issues. One mom said actually that, like, when her child says to her, "Mama, there is no food," it actually makes her angry, so she can't be patient. She said it makes her angry because she knows that she cannot provide, and she wishes she could sell her shack and just go to live with her mother, so that she could turn to somebody else when her child says there is no food. And she wants to say, "Don't call me mama," because with that notion of being a mom, there's this expectation that you can provide everything for your child. But it's such a struggle to meet basic needs. And so, yeah, so she, she was speaking about hunger and the difficulty of being able to explain to a child that there is no food. And then the second photograph is of a mother whose husband was working. So there was a husband in this picture, but she said he does the easy work because he goes out every day and he earns the money. And for him, then he's provided he's been the provider and he's fulfilled his role. But she has to do the mental gymnastics of how that very little bit of money, which is insufficient to deal with all the expenses, and how she's going to either decide, make those mental decisions on, is this money going to go towards food, or is it going to go to electricity or rent or children's school costs? But it can't cover all. And then the third picture is of a mum who spoke about the difficulty of accessing jobs and income. She said that, it's often these jobs are gate kept. So the gatekeepers in the community often keep jobs for men, and that if you want any information around the availability of jobs, there's a sort of, you've got to reciprocate with something. And so that's either financial or sexual or some other favor, that if you just want, not even if you want the job, if you just want the information about what jobs are available. And so this really makes it difficult for women to access jobs. But also, once you do have access to some jobs, the jobs have not been designed with an understanding that care still needs to take place. So who's going to care for children or other dependents if a mom goes out to work? And so what the mothers were telling us is that they weren't earning enough to cover the cost of childcare and their commute. So taking on a job for the day would often put them in debt. And yet they wanted to work. They wanted to be more than a mother. They wanted to learn. They wanted to upskill themselves and progress and have work to be proud of. And so those were some of the deeper stories that we got insight into. The mothers then shared with us their needs. So their needs were very much around the daily need of children's infant sort of everyday nappies and wipes, baby cereal, but that it was a constant need that they just didn't have enough money for. So that one of the big needs was also the need to earn, the need to have an income, the need to have sufficient money to be able to afford basic necessities, but also the need for male role models in the community, which was lacking, and the need for safety. A big need was around safety in these areas, that in the informal settlements and in the Cape Flats where the mothers lived. So many of them spoke about, just how difficult it was to feel safe as a woman, and worrying about their children. So their children couldn't play outside because of the gang violence, but their children also couldn't play inside because the shacks often didn't have sufficient space, for example. And so a kettle might needed to have been on the floor. I'm going to again just tell you one story that so what we asked the mums to do is to put up their 6 photographs, and each mum individually had a chance to tell their stories, but then we invited a collective response. So we'd say to the mums, is this something that resonates with others in the room? And so there became a collective story around it also, and a collective analysis. And so this mum speaks about the invisible dangers. She speaks of her child, her children, one is 2 and one is 7, who have to walk down this hill every day, only to, after this long walk down the hill, to get to a long road that they need to take to get to school. And so it's a very tiring journey for these little children on their own, because she often can't accompany them. Either she's going to work for the day, and so doesn't have the luxury of the time to accompany them. But he's really worried that, on that road, children have been knocked down. On that road, there are older children who bully the younger children. And so she feels like she's got to hold her breath until they come home, because she's so worried that something will happen to them during the day. And in the same neighborhood, there is also a mobile clinic that only comes on a Tuesday, but the mobile clinic is at the opposite end of a forest. And so again, to access that mobile clinic, the women have to pay somebody to accompany them so that they are not assaulted in the forest on their way to the clinic. But when they do get to the clinic, often they are told that the clinic is out of stock of their vaccination that they needed, or the clinic is out of stock of the, immunization or the contraception or the medication that they needed. And so they are asked then to spend more money to either go to a private pharmacy or to go to the government hospital. And then that started a conversation around accessing health services at the hospital. And a mom said, when you are poor, there's just no sense of dignity that you're treated with. And so she said, I had to put my baby on the ground and scream until I got some attention. And another mum added that, she was, after spending hours and sitting on a metal bench for a really long time, and after her child was seen to, she was discharged at 3 a.m. in the morning. And it just shows that we're not thinking around an individual who's got care needs and what does it mean for one mum who's got to navigate these different spaces, but then to be discharged at 3 a.m. in a context where it's just not safe to get home and there's no transport to get home at that time. How does this mother get home? So we asked the mums to, I'm going to hand over to Fiona.
Okay. So
Tell us
after a
what's
series
next.
after a series of workshops where we'd kind of gone through all of these processes of mums describing in really great and very intimate detail what care really looks like, both the joyful side of it and the side that keeps them going, but also these very, very complicated interlocking struggles, which are largely caused by institutional and policy failures. We then asked them to draw those together, to think about what their strengths, needs, and struggles were, and then how they intersect, how they see themselves as experts in their motherhood, and what are the most relevant interventions for them. And that was the really critical part. We are partnered with a civil society NGO, and we're partnered with government, with the Western Cape government, provincial government. And what we really wanted to do was create grounded policy, ideas that come from the particular struggles that women face, not a generic, oh, we'll fix this and that, but these are the actual, real, on-the-ground, full-face issues. So the pictures that you can see before you are mothers describing, in the picture on the right, they're describing the interlocking circles of the immediate community, then the kind of broader community with schools and police and transport, and then the larger community, which is partly around work and religion, places to socialize, the state, the access to public grants. And then the picture on the left-hand side is an extraordinary attempt to link together these different dimensions. So what you're actually seeing there, I don't know how easy it is for you to see, but the top of the picture on the left says strengths, and the women describe their strengths, and we used one word to describe it, and then their struggles, and then their needs. And then we tried to link all of those, and you can see how complicated and interlocking those are. These are big, I think the 3 big A3 sheets that we put out on the floor, and then Jaga kind of knelt down and drew these, but it really gives you a sense of how deeply interlocking the issues are, that you can't just approach this with a one-size-fits-all approach to policy, and particularly not when that policy is made on the basis of some imaginary of the middle class. Can we move to the next slide?
Yeah.
So then we asked the mums to put out a call to action. So we asked them to think really hard about which were the most critical and vital of the issues that they face that they would like to see addressed first. And what you can see on the screen is the 3 calls to action that they generated. So they're big calls, big generic framings. The need to end the domination of men was paramount. The need for financial security, and then the need for safe housing. So out of all of the different issues that they'd raised, those were the 3 really big points, but we didn't leave it at that. We asked them to bring into that conversation specific issues that they would like attention paid to. So, for example, where they're looking at the need to end the domination of men, they asked for gender sensitivity training. They asked for workshops to enable people to understand what the toll of patriarchy is on women. They asked for government to intervene to really start to talk about how to make gender equity a reality, not just something pretty in our constitution. We have an astonishing constitution, which is quite pro-feminist in many ways, but it doesn't quite make it into the reality of low-income women and their lives. But there were also very specific questions that they really wanted some engagement with. The one was around family strengthening programs. One was around support groups, just very basic social media-based support groups where women can share their experiences and get ideas from others. And then they flagged also the absence of social institutions. There's very little place where people can go that is safe and secure, where they can relax. So part of it was also speaking to gender-based violence and the very particular ways that gender-based violence enters women's lives. Similarly, with the call to action on financial security, they were asking for jobs, not just to make jobs, which is very much a kind of big policy, but to make jobs close to home, because apartheid spatial planning means which has not yet been undone, means that people live in one place in essentially dormitory suburbs, but they work very far distances, which cost a great deal of money to get to. So they want work that's close to home so they can manage mothering and employment simultaneously. They can be close enough to reach their children when they need to get them from school. They can work in immediate environments, so they're not spending so much money either borrowed or used from incomes that they're earning. So each of these three, I won't go into them all in detail, but each of these three flags a really major issue that the women themselves prioritized as reflecting their needs at this moment in time. What we then did, let's go to the next one, was out of this very large body of work, we generated a concept, and the concept we think is a very lovely one. It is this new concept that we have formulated called Motherload, and we think about that in respect of our very long apartheid and colonial history, where male migrants were sent to mine the load, the ore load, leaving women to shoulder the responsibility for families. And so we're really trying to place in historical context the ways that women in the contemporary moment are also carrying these long histories of alienation and exclusion from work, from family life, that are a direct product of colonialism and apartheid. So what you see on the screen in front of you is our definition of the Motherload. This is a piece, it comes out of a piece that we've just written for an encyclopedia of African feminism, where we explore this work and we develop a concept, and we're now landing that concept into a variety of spaces, which include government. It includes our partner, our Flourish, you see on the bottom of the screen there. We are now funded by the IDRC, so they're taking this work and embedding it, and then speaking into academia and into places like the World Bank to really foreground the extraordinary weight of care, not just the material effort of care, but the consequences for women in terms of their social and emotional health when care is not available to them too. Part of what we then did was invited them to put together an exhibition. So let's go to the exhibition, I think. This was at the end of last year, and we offered an exhibition where the women put up this whole long journey that we'd been on together. Unfortunately, our sound's not working, so I'm going to overspeak this. We hosted the exhibition for 3 different constituencies. The first was for the women themselves and their families. They were allowed to invite people from their community, their families, their friends, to come to hear the story of the Motherload, to see it writ large on the screens like this, on the walls like this. We hosted it in a community hall that was very central in the struggle against apartheid. So it was a very meaningful place. And people were invited just to come and see what this looks like and how it works. We then also invited our government partner and civil society partners to come and see, particularly to pay attention to the demands. This is what women are identifying as core to their needs right now. And those were so successful that the women asked us if we would host a 3rd exhibition, which was open to the general public. And what you see on the screen here is some of what you see is the general public, who were invited to come and just engage and interact. The mothers were there to speak with people and to explain what they were doing. So we really were focusing on women as the core of this body of work as experts in their own lives. And I think we can move to the next one. I'm conscious of time. The project is now scaling up. We have IDRC funding, and what you see on the screen on your left-hand side is a graphic representation of how a cartoonist at the IDRC conference saw the Motherload in relation to the available facilities. It's just such a beautiful depiction of the Motherload and the career and the baby and the load and the pregnancy and then the patriarchal structure in front of us. So we thought that this was a very lovely way of trying to think about how the Motherload impacts on people. We've scaled the project using this proven methodology of photo voice and participatory action research to include fathers. This was a direct request from the mothers. They said, bring the problem into the picture. So the first father projects begin this weekend. But the idea here really is to shift who's recognized as a knowledge expert, to really make it clear that the people who should be making policy are the people who the policy affects. We're deepening our existing work with the women's rights organization Flourish, who are our first partners, and we're expanding our government and NGO partners to really try to transform norms and to foster care economies, but also to change the way that government thinks about expertise and thinks about gender and thinks about the interlocking inheritances that we've received from apartheid. Let's go to the next. Okay, so this is our last slide. This is the team from our first Motherload project. You can see it's a combination, the people in front of you are a combination of the moms, the academic team, our various partners who are all listed on the right-hand side. And the key critical point for us was that we're all experts. The mothers more so than anybody else in the room, which was a fairly revolutionary moment for our partners. I think we'll leave it here and hand back to Shelene to continue facilitating.
Yes, thank you. Thank you so much, Ameeta and Fiona. And I think just to say, I may not have said it previously, but if you would like to ask any questions or make any comments, please do so in the chat. And then at the end of all the presentations, if you'd like to say anything, please raise your hand and we will call on you. And so I'd like to hand the floor now to Dr. Bephyer Parey. Bephyer, the floor is yours. Right, Bephyer, you're muted. What, is it on my end? I'm not hearing you. Is anyone else hearing Dr. Parey speak? No. Now we've lost the sound.
Dr. Parey, can you please try again? No, we're not hearing you. Could you check your audio?
Are you hearing me now?
Yes, we are.
All right, great. Thank you. So I apologize for the
No problem.
technical difficulties there. Thank you, Dr. Gomes, for the kind introduction. I am very honored to be part of this panel discussion today. And so I'm just going to shift gear a little bit because my work is actually going to focus on older persons and specifically older persons with disabilities because that's my research focus. And so as we know, care has always been a social issue, but it's more so now because of the aging dilemma. And older persons are gradually contributing to a greater share of the overall population. And to meet the growing care needs among older persons, aging in place policies are encouraged. And so this is where support and resources are provided for people to continue living in their homes and in their communities. Now, aging in place is preferred by policymakers for obvious reasons. It is cost effective. It is also preferred by many older persons. Of course, older persons want to continue to live in their homes and in their communities. However, the success of aging in place policies depend on the unpaid work of family carers who sometimes experience strain and burnout. And so I'm presenting specifically in the context of Trinidad and specifically on the research done for this context. And there is a saying that we take care of our own, and we do. We do view care as a duty, and this definitely is historically true. But given that there has been so many sociological transformations, such as changes in the family structure and inclusion of women in the workplace, it begs the question of whether this care view still holds in Trinidad. So what I had set out to do through some research is to examine the views among Trinidadians towards care, and specifically the care of older persons with disabilities. So disability studies, like as I mentioned, is my primary research interest, and so hence the focus on older persons with disabilities. But we also know that as aging occurs, the prevalence of disability increases. And I also want to draw attention to the chronic illness dilemma across the region, including Trinidad and Tobago, which also has implications for disability prevalence in the study context as well as for the region. So examining the care views for the subpopulation can yield useful insights. So what emerged from the research was that there were 6 care views, and I'm going to go through them. The first one is care as an obligation, where the family members see the care of relatives as their duty, the historical view. Then there is care as a cost to the individual, which refers to emotional, mental, and physical strains. And there's also a cost to other relatives. So other relatives could also experience these same emotional, mental, and physical strains when older persons with disabilities are being cared for at home. Then the fourth care view, care as a financial burden. Caring for an older person with a disability can incur a financial cost, and there are many costs to take into consideration. We have transportation, supportive devices, as well as home modifications. And then the other 2 care views has to do with care as labor. So the first care as labor view represents a disruption to personal, family, social, and work matters, as well as overall progress in life. And in other words, it's a disruption to life activities. And then the second care view as labor has to do with the idea that persons would have to quit their jobs to care for older persons with disabilities. So these were the 6 care views that were identified. And in addition to the identification of these views, I also assessed the prevalence of these views. So the last care view I mentioned about, that is the second care as labor view, this had low prevalence. So Trinidadians did not really believe that they had to quit their jobs to care for older persons with disabilities. And just coming back to the question I would have asked before, what about care as a duty? What prevalence did this have? And so it had a medium prevalence. It was a dominant view, and may I say is a dominant view among Trinidadians. I think what needs to be noted is that the other 4 care views, care as a cost to the individual, care as a cost to other relatives, care as a financial burden, and care as a disruption to life activities, had the same prevalence as care as duty. So what this means is that there are multiple views of care. They're all equally dominant. And therefore, in centering care in the care economy, it's very important for care policies to incorporate these multiple care views. And as it stands, policies are hinged on family care. It's hinged on the view that care is a duty. The policies essentially speak to the idea that families will care for their members. But as we can see from the research, the situation is more complex. And so I just want to touch a bit on the gendered nature of care. Dr. Gomes would have spoken about this, and the presenters as well that came before me. And so we know that women are the ones who usually take up the carer roles. So what I looked at was the differences in the care views in the context of gender. And interestingly, the only care view where there was a difference was the first care as labor view. That is where there's a disruption in personal, family, social, and work matters, as well as a disruption to overall progress in life. And so what exactly is the difference? So for women living with older persons with disabilities, they viewed care as a disruption to life activities less than women not living with older persons with disabilities. So it means then that these women living with older persons with disabilities are more likely to take up carer roles. And this is kind of obvious, right? I mean, the situation is right in front of their eyes, and therefore it might be hard to neglect. But I think what generally gets neglected is the fact that these women, when they take up the carer roles, is going to cause a disruption to some aspect of their life. Without adequate support, there is going to be a disruption. And then I'm sure each of us could think about women in our network whom, after taking up care responsibilities, would have limited career prospects and limited opportunities with regards to different life activities. And yes, sometimes women intentionally accept the limited opportunities to provide care, but this is not the case for everyone who takes up care. So support is needed for women taking up carer roles. Another interesting insight coming out from the research is the impact of education, specifically secondary school education. Women with secondary school education viewed care as a disruption to life activities less than women with primary school education or no education at all. And this is a good campaign message for keeping girls in schools. I mean, there is a demand for care, but the care dynamics should not involve one of strain, or I say continue to involve one of strain or continue to involve people who are the most vulnerable, as is the case of women who perhaps has no education or very limited education. So again, the whole point of support needed for women, for girls staying in schools. In addition to care views, I also examined care potential among Trinidadians regarding the care of older persons with disabilities, and specifically with regards to their willingness, availability, and perceived skills to provide care for older persons with disabilities. And so as you can see from the chart, 76.5% of the respondents indicated that they were willing to care for older persons with disabilities. What you can also see is that a lesser proportion was available to care for them, 54.38%. And some inferential statistics was conducted, and it's safe to say that the proportion that are willing to care for older persons with disabilities is significantly different from the proportion available to care for older persons with disabilities. And then lastly, in terms of skills, perceived skills, fewer persons perceive themselves as having the required skills, 46.31%. And again, there was a significant difference in this proportion compared to the two others. So there is a potential dilemma if there continues to be a reliance on care provided by family members only. So without acknowledgement of the multiple care views and the reduced availability of carers, there will be shortcomings in the care received by older persons with disabilities. And I actually have evidence of this. So I would have done research as well on the well-being of older persons with disabilities in Trinidad. Care was one of the well-being indicators considered important to older persons with disabilities. Unfortunately, it is a deprivation that they experience. And so these persons, they're deprived in all the well-being indicators, including the basic needs of food, clothing, and shelter. But as you can see from this slide, the statistics indicate that care is a larger deprivation for older persons with disabilities. Now, the reasons for the deprivations are many. Firstly, the inability of relatives to provide care due to work and family obligations, other family obligations. Again, this is linked to the idea of them being available to provide care, or rather not available to provide care. Then the health status of relatives. Of course, if relatives are not in good health, they would not be able to provide care. So that's a second reason for deprivation in care. This one is something that's not discussed a lot, poor relations. And I'm talking about the idea that it is assumed that cordial relations exist among family members. This is, however, not the case. And therefore, in a case where there is a lack of cordialness among family members, of course, care will also be lacking. And then lastly, while persons recognize that there is a need for care help, they're unable to seek the help that they require because of the cost of caregiving help. And we're talking about more formal help care. But of course, this also is linked to the idea that care work is not recognized and rewarded as it should be. And if you recall the definition of aging in place, it's not just about aging in the home, but also continuing to be part of the community. And so the provision goes beyond the family to include the social network and the family network. The presenters before would have spoken about the importance of the social network. And so all of these make up the social context. However, what the findings indicate is that there is no current community initiatives regarding care to ensure that older persons with disabilities are integrated in their communities. And then the idea of a social network to support care seems to be missing from the dialogue regarding care among Trinidadians. So therefore, the social context needs to be developed further in Trinidad. Something that was quite interesting emerging in the research is the identification of another component of the social network, specifically the workplace network. And some might be wondering why the workplace network is included in the social context and not a more formal context. I'll get to that in a minute. But essentially, the participants indicated that workplace accommodations, such as time off from work with pay and flexible work hours, could support carers. So coming back to why it's why workplace network is within the social context. So in a study that was completed in the last year, within the disability studies research cluster, what we learned is that for carers who are employed to have time to provide care, and this is in the context of persons who would have recently gotten an amputation, for them to be able to do that, it was actually some informal work arrangements that were made. They just having some informal good relation with their employer, and that employer understanding the situation and providing some flexible working arrangements. It's nothing formal at all within the workplace. Of course, little is known about formal measures in general in the context of Trinidad, and of course is an area that could benefit from future research. But generally, the workplace network, there is importance. It is recognized that it is important in considering the social network. And then the last point I actually want to draw on is whose care should we be centering in the care economy? And yes, the population is aging. Of course, just a reminder that I'm speaking about older persons with disabilities. The population is aging. Care needs are growing among older persons, including those with disabilities. However, we cannot neglect the needs of the persons taking on the carer roles. And so the ethics of care framework, that's what's displayed on the slide. Though it's a Western framework, it does have some relevance. So the ethics of care framework recognizes the various rights with regards to care, namely the rights to self-care, to provide care, to receive care, and to also reject care work. And in recent research done on the well-being of relatives of amputees, the same research I was mentioning a while ago, what came out of that research is that many of the carers were prioritizing the care of amputees over their self-care. They were sometimes postponing and canceling personal goals in order to support amputees. And I make this point because, again, it is important to ensure that measures are in place to safeguard the well-being of carers. So while there might be care demand among older persons and older persons with disabilities, the policies and whatever frameworks are in place to ensure care is provided needs to take into consideration the well-being of carers. And moreover, as pointed out previously, some persons are unavailable to provide care. Some of them may not have the skills to provide care. There's a lack of cordiality in some family relations. So what is in place for these situations? And from the research, this is not my idea, this is the findings from the research, it is an expectation that homes for the aged could fill the gap. In another study where I looked specifically at attitudes towards care of older persons with disabilities, for Trinidadians who had negative attitudes towards the care of older persons with disabilities and their inclusion in the home, they believe that homes for the aged would be best suited for older persons with disabilities. They believed that they would they are more equipped to provide care for older persons with disabilities and perhaps better care as well. However, just generally across the Trinidad population, there is a mistrust towards homes for the aged, again, based on research, and there is therefore a need to implement a monitoring system to ensure care standards at these facilities. And so that brings me to the end of my presentation. I'm just going to quickly summarize. Essentially, there is a growing demand for care among older persons with disabilities. Because policies are focused on family care, it means that families have to take up carer roles. More so, women within the families have to take up these carer roles. And what the research is showing is that there's a need for more support for them, various types of support. And so I'll just end my presentation here and say thank you for your attention, and I look forward to the question and answer segment.
Thank you very much, Bephyer. And so, yes, please do put your questions and your comments in the chat as we then move on to Dr. Blake. Dr. Blake, the floor is yours. Thank you.
Good afternoon, and thank you again for this opportunity. Welcome to those who are listening in and putting their questions in the chat. I will be ably assisted by Mrs. Maynard, who has already started sharing the presentation. And my topic for today is Caribbean Family Elder Care, Policies and Practice for Equity and Support. So it's nice to do a tag team with Dr. Parey, because I will be continuing the discussion on what's been happening in Trinidad and Tobago, as well as highlighting some of the research from Jamaica and Barbados. So we'll move along to the next slide, where Yes, we can't forget the reason why we're gathering. So happy International Care and Support Day to all those who are carers with us. We acknowledge you. So the order of the presentation is as follows. So I'll begin with a definition of care, which is not a straightforward concept as most sociological concepts are, and give some context with regards to the Caribbean. As I mentioned, the research highlights and regional international policy frameworks such as the Universal Declaration of Human Rights, Caribbean Charter on Health and Aging, the Madrid International Plan of Action on Aging, and the San Jose Charter, and what the provisions are for family caregivers, in particular of older persons. Then I will go on to some policy recommendations. Now, how should we define care? And I'm drawing from UNICEF 2023, and they point out that it refers to direct contact activities that seek to guarantee the right to physical, emotional, and mental well-being of dependent persons, a grouping that can include children, people with disabilities, people with chronic illnesses, and older persons. The definition includes direct care and supervision, which many women perform, and some men as well. But in this case, for this discussion, we're not referring to indirect care or domestic work. Likewise, it acknowledges that care can take place outside of the home, including in state and private sector care and support facilities and in the community. Now, what has been happening in the Latin American and Caribbean context? As I indicated, I'll focus more on the Caribbean, but it applies also to the LA context. There is a care crisis, as is indicative from what the earlier presenters mentioned, both in South Africa and what Dr. Parey said about Trinidad and Tobago. So it is characterized by an increasing mismatch in supply and demand of care and support, which has taken hold over the several years. In particular, it became evident during the pandemic. All right. Some of the factors that we need to be aware of is the broad context of structural gender inequalities that was mentioned at length this morning, a lack of widely accessible care and support services, and an increase in the demand for care and support. As Dr. Parey mentioned, Trinidad and Tobago is one of the aging populations in the Caribbean region. We have over 10% of the population being 60 years and over. Now, let's look at a study done by Brown and Murphy in 2018 with regards to the barriers to informal caregiving of persons living with dementia in Barbados, the use of phenomenological inquiry. And we're seeing some of the themes mentioned by Dr. Parey being translated in this study and in the others that I will highlight. So, imbalanced family dynamics. Yes, Dr. Parey talked about poor relationships with relatives. So to quote one of the participants, it says, everybody is not patient unless you know or are trained with treating a person with dementia. The financial and time constraints is a consistent theme. This particular participant said, money, because if we had money, I don't have a Jamaican accent, sorry, about a Bajan accent, so I won't even try, right? Dr. Gomes, you wouldn't have me do that. Because if we had money, we'd be able to get somebody to come in. You could pay somebody or transportation or take her to daycare. So there is consideration for community-based care outside of the home, but they could not afford it. Dissatisfaction with formal care services. Sometimes the people don't get treated. They tie them there and pull them there within the institutions. But when the family come and look for them, they're all smiling. Misunderstanding of complex symptomatology when it comes to dementia. What happens when the day comes that she can't do everything and I have to start dressing her? And how is she going to like that? So the rejection of care from even the person who's supposed to be receiving it. Now I move on to highlight some of the key aspects of the recent Barbados National Policy on Aging. It was revised and updated. So we're now talking about the 2023 to 2028 version. And it speaks about strengthening and expanding existing formal long-term care services, working closely and collaboratively with existing formal long-term care providers, and providing and managing necessary support services, training, and related resources such as human, financial, and technical for informal caregivers. So this is very commendable. And I want to just say that I've noticed a shift in the policy literature, whereas in the earlier versions of commentary about policy, there was an a significant emphasis on informal care, we're seeing a pendulum shift where we're reverting to recognizing we still need to have these more formal care positions, right? And alternatives and options. So you'll see that throughout the discussion. Now, to continue with the Jamaican study by Robinson and others in 2021, where they mapped the long-term care in Jamaica to address the aging population, they note that the long-term care system depends substantially on informal care, unpaid at-home care that mostly female relatives provide, and paid care provided by domestic workers and others who do not receive legal employment contracts. And we heard that from Dr. Gomes, how many trillions of dollars would have been dished out if persons were really paid for the quality of work that they provided informally. Now, based on their literature review, they found that Jamaican women spend 40 hours each week in unpaid care. That's a full work week. Far less if they are juggling formal work as well, but be it part-time or full-time. The average daily time spent was 249 minutes by women, whereas caring for dependent persons was 3 times for men when compared to women. So men would have worked just about 90 minutes. And that echoes what is going on in South Africa. I remember that story that Professor Jaga and Professor Ross would have shared from their research, where the mother complained in terms of childcare that the man is going and getting formal work, but it's not covering all of the expenses, and it applies also to elder care as well. Of course, we do have some men I would have come across in my research who go beyond this average, all right? So we note that as well. And then there's the societal opportunity cost of providing unpaid care, predominantly borne by Jamaican women who had less access to resources and paid work than men did. And this would have resulted in compromised health and well-being of other dependents, such as children. So there must be this balance as to this care dynamic. Now, moving on to look at what is available for caregivers and to meet the requirements of care, the cost of care, it's interesting that there is the national insurance provision in Jamaica, but 80% of the poorest quintile do not have access to this pension. And you find that it's mainly the middle class. This is another theme that is a common thread in the presentations today. The middle class is more likely and upper class access these supports, whereas persons who are in the lower income bracket, they are providing care support to the middle and upper classes, but do not have the resources to care for their own relatives and themselves. So this particular research concludes that caregivers must be able to receive compensation to get reprieve through in-home respite care and or to benefit from live-in trained home care workers who will not be abusive. This type of legislated and state-financed care infrastructure for at-home and community-based long-term care and dementia-inclusive infrastructure can help future-proof Jamaica's aging population. I just want to quickly highlight the existing policy for senior citizens that the Ministry of Labour developed for Jamaica in 2021. And it speaks about the integrated responsibility. Again, very important, this diamond of care, where we have stakeholders engaged and we're not putting the burden solely on female informal caregivers. And we need an enabling and supportive environment where the policy is grounded. So I love that approach to policy development that Professor Jaga and Ross spoke about. And I'm hoping that to see more of that happen in our region if we are to achieve this of having supportive policies and programs. Now, thematic area 5 of this senior citizens policy speaks about family integration and intergenerational transfer. So there is explicit mention of provisions to support caregivers. So it speaks about developing a caregiver network and training. Training is something that has consistently been said in the policies regionally, which is consistent with the Madrid International Plan of Action on Aging. Establishing a national public service program for support at community level, all very well and good. And there's also mention of family activities involvement. And I love that it also mentions respect for privacy, personal choices, which Dr. Parey spoke about in terms of the ethics of care. So yes, and I will mention it some more when I speak about Trinidad and Tobago, the duty of care is there. And I note that Jamaica has a Maintenance Act, which requires that adult children as far as they are able, should be able to care for their older parents. But I'm seeing that in 2021, there's this balance as to personal choice, which we need to consider given all the other variables that may make caregiving challenging. So it's not a one size fits all. We're not denying that care is important, informal care, but there must be options. So now I move on to looking at research done by myself on family care for frail older persons. So you will have access to more information. I've included the link in the presentation when you get it. But the key themes, if we can move to 2 slides down, the key themes for caregiving and care recipient experiences of family care in Trinidad and Tobago, there were the positives, self-oriented benefits like personal growth, enhanced care relationships. People were appreciative of their spiritual and religious blessings. And then there were the other oriented benefits, such as appreciation from others who would positively comment on the care and the sacrifice being made, and observing the well-being of those being cared for and the support that some persons received, which again, it was not consistent for everyone. But then there were several challenges, as you see in this table before you. Again, you see at number 3, financial cost of care, problematic behavior, lack of knowledge was a repeated issue, so that ranked at number 1. And that's in terms of the caregiver experiences. We also see issues like poor health of the caregiver, back to the point related to the ethics of care. Should a sick caregiver be obligated by duty to care for their parent without sufficient support, right? So we have to consider all these variations. And care recipient experiences, let's look at some of these. A main issue for the older persons I interviewed it was before the pandemic, so I'm glad that Dr. Parey has done more recent work, but the issue of compatibility, because even though the constant theme was people cared because it was their duty, that is a cultural phenomenon that was observed throughout my study in Trinidad and Tobago. Caregivers the care recipient did not want to feel they're doing it for me because you have to. So, that compatibility, not only in terms of the motivation to care, but even in terms of their personalities, sometimes there are these old conflicts and who's an introvert, who's an extrovert, and all these dynamics. I may not necessarily want my child to care for me. This is what some of the care recipients would have said, even though the child is willing. So there's caregiver willingness, as I hinted to just now, the ability of the caregiver to care, because sometimes the older person is like, yes, she's helping me, but I fell however many times because she doesn't know how to lift me. And I remember that from a case with an older woman in her 80s caring for her mother who was close to 100. So she herself, the caregiver, had health issues, right? Caregiver availability, a lot of persons had to return from other countries where they had migrated to for decades to care for parents who became very ill and frail, especially when maybe siblings, or there were no siblings that were born or no siblings that were survived. They had to immigrate into the country to get care done for their parent, which is a whole adjustment. So I just wanted to highlight some quotes quickly to show the thread with the research that was shared before. And there are other themes that you would have gathered from what I shared. So in terms of lack of support from relatives, one of the male caregivers mentioned, sorry, this is a female caregiver, nobody calls him, nobody comes, nobody asks a question, nobody say, okay, let me spend an hour or two with him, or half day or a day, so that she could do other things that she needs to get done. And so there's this feeling of being locked in and alone. Financial constraints. My medical bill is exorbitant. This is from a middle-class care recipient. I spend my own money to finance the medication. CDAP don't provide it for her heart condition. Dissatisfaction with formal care services. In looking at the various geriatric homes, it was appalling to see what others accepted as a good place to put their loved ones. This was feedback coming in from the survey aspect of the study. Complex symptomatology, problematic behavior. So this particular female carer noted that before her father started dialyzing, he was starting to get violent. He would lash, hit you for nothing. He would get mad and start shouting. So there are all these issues. And this was related to his kidney problem. And another quote here with regards to a mother-daughter dynamic. She's a very strong personality, very difficult to deal with. This was the trend from since teen years go forward. She could be very demanding even with the caregivers. Now, I'll look, and just to backtrack to say that the particular research included in-depth interviews, focus groups, and an online survey. So this is now some of the findings quickly from the survey. Now, in terms of caregiver needs, when we're talking about what is the policy approach and is the key issues that need to be targeted, we see information and advice about the type of help and support that is required is something that caregivers definitely want. Moving on to look at the financial responsibility for health and social services for older persons. You know, person said that is the role of the government, right? Even though the family came in with half of the respondents. But I want to show the next graph where it looks at who should pay for support for the caregivers. If we could move to the next slide. And we always hear about this dependency syndrome in Trinidad and Tobago. Everybody want the government, the government, the government. But people were saying, I would pay for my family to get support. Now, there's a bit of need for clarification as they understand the kind of support that the carer needs, right? There were extremes in how that was spoken about. So one family, they would have paid one of the siblings, 5 siblings. She left her work, her formal work, stayed and cared for the parent. Many of the siblings were overseas, so they had the finances to support her as a caregiver. She was given a salary to care for the parent, and she was given a paid holiday each year. That is an exception. That is not always the case. All right. But we hope that we hear more stories like that going forward. And to reference the National Policy on Aging, which is due for an update in Trinidad and Tobago, the 2007 version, and it has started to be reviewed, I would say. But again, there's this emphasis on training and support services. We need to go a bit further and speak about the respite care and so on. And I will talk about even vouchers and payment for care. But again, we have to be mindful of the economic context that we're in and balance all of those factors. Now, to speak about the international policy frameworks that impacts on Caribbean policy development for older persons and caregivers, I had highlighted that in my introduction. So I just want to point out Article 25 of the Universal Declaration of Human Rights. And it speaks to the fact that everyone has the right to a standard of living adequate for the health and well-being of himself and his family, or herself and her family, including food, clothing, housing, and medical care, necessary social services, and the right to security in the event of unemployment, sickness, disability, widowhood, old age, or other lack of livelihood in circumstances beyond their control. So this is since 1948, we're seeing this whole ethics of care being somewhat principled into these major policy frameworks, and we're coming full circle. So I'm saying that in terms of the way forward, we do not need to reinvent the wheel. We just need to shine the light on some of these principles even more as we get to a place of balance. Moving on to the Caribbean Charter on Health and Aging, 1999, the key objective was to develop and initiate comprehensive programs to promote and protect the health and well-being of older persons. So we're talking about creating a supportive environment. So it's implied that this will also positively support the work of the informal carer. Sensitizing communities, developing a rights-based public health policy. So we're strengthening the infrastructure that is available. So persons, we do have experiences about persons going in the daytime for medical care and leaving at night or the next day. So the story shared by Professors Jaga and Ross was also very familiar. Enhance and support collaboration between government, NGOs, and the media. So those are some of the considerations, and it's usually reflected in our national policies in the region. And then there's the ever popular and comprehensive Madrid International Plan of Action on Aging, 2002, where we look at advancing health for older persons. And there is some mention explicitly about supporting the needs of the caregivers under mainly Priority Direction 3, which is ensuring an enabling and supportive environment and care and support for caregivers. So again, the point about education for health care workers, but also for the informal caregivers and access to training. And I'll just put a plug in here for a PAHO training program for persons caring for individuals with dementia, the eye support program. So you can Google that. There's a full free online course if you're looking for that kind of information. Right. So what else does MIPA say concerning the care? Back in 2002, it suggested that that particular instrument, that community or informal care is not always ideal. And we have to make sure that when we create policy, we're not skewed and ignoring these nuanced or very overt pleas for caution and balance, right? So without adequate assistance, Section 104 speaks to the fact that family caregivers can be overburdened. We knew this since back then, that formal community care systems could lack sufficient capacity. Residential care may be preferred, and there needs to be a continuum of affordable care options. Back to the issue of choice. Now, they also underscore the need for the participation of older persons in assessing their own needs and deciding if they want formal or informal care. And interestingly, when I went to do focus groups in Tobago with older persons, half of the participants would have indicated they would want to go to a home of an institution. Now, Tobago is considered to be more traditional than Trinidad, more family oriented and so on. So that was a very noticeable variation from the expectation as to what would have been shared. So we need to be mindful of, again, the need for choice to balance both, again, the informal and the formal. I want to also highlight the point made by MIPA about the provision of the continuum of care, caregivers receiving psychological. We talked about the mental health impact, about how that impacts, on the caregiver, the economic, social, and legislative issues. And we cannot ignore the fact that a lot of older persons are caregivers, which I kind of referred to in the case I mentioned about the 80-year-old caring for the 90 plus. So we need to bring this kind of balance that was in our policy instrument since over 20 plus years ago. The San Jose Charter on the Rights of Older Persons in Latin America and the Caribbean, which was drafted in 2012 and made official. That particular instrument speaks to the need for developing home care services, providing support for families by introducing special services for people who care for older persons, if we can move to the next slide, and promoting initiatives to achieve a work-life balance as a strategy for improving the capacity of families to provide care. So where do we go from here with all these wonderful suggestions and recommendations? Let's just, and I'm not making a plug for Nike, let's just do it. That's the way forward. Let's just do it. Bring it on, you know? And I want to again refer to the work by Gallian et al., who did this paper for UNICEF. And they spoke about these 3 R's and the importance of integrated care systems. And I note that the Motherload project would have mentioned these 3: recognition, reduction, and redistribution, with recognition pointing to the social and economic value of care, reduction of unpaid care work. So we're not assuming that the woman is always available or even the man to care, right? But care is important. Please don't get me wrong. It's good if we can. Let's do the best with what we have. And again, make sure that there is balance. Redistribution of the care burden within households, primarily for women and girls to men. So I love that your participants, Professor Jaga and Professor Ross, called for you to continue the research and call in the fathers when it comes to care for children. And I want to also note that the Motherload project extended this list to include represent and reward. Now, in terms of what the integrated care system speaks to, again, a rights-based approach, guarantee the rights of both those cared for and the caregivers. We have to maintain that ethic that Dr. Parey spoke of. Incorporate co-responsibility between families, the state, and the private and volunteer sectors. Draw on greater public investment. Unfortunately, due to time, I can't go into comparing the insurance approach used by Germany and the tax-based approach used in the Nordic regions, such as Sweden and Denmark. But that's something to consider as policymakers, that the tax-based approach seems to be more suitable. It would only allow for persons to make out-of-pocket investments of 5% on average. Spain, it was a little more because their culture was noticeably different when it comes to care. They tended to, the population generally preferred informal care, but the insurance-based approach used by Germany, according to the research, meant that out-of-pocket provisions by caregivers and older persons would have exceeded 24%. So that's something to note as to who pays for care. But back to this slide here where I spoke about mentioned public investment, I just want to note also the right guaranteed by the state with regards to reconfiguring the responsibilities for care as to who does it. And the key defining principles, again, you would see reflections from MIPA. If we go back to the slide before, universality, that everybody should have access to decent care. It's a right. Going back to the Declaration of Human Rights. Accessibility, right? We should all be able to access it. You see, so that picture with the children having to go down that path to get to school and the treacherous paths to get clinic support in the forest in South Africa. Again, these stories are not unusual for our lower income groups in Trinidad and Tobago. I remember a story where one of the participants was in not a very rural area. We don't really have a clear rural area in Trinidad and Tobago, as in some other territories. And, you know, they're on hills with little paths, and you can't get down to the hill as a person with a disability, older person, or even the caregiver properly to get the bus, even though the bus is free. Taxis can't go up the hill. It's really challenging in some spaces. So access, equity, redistribution of care so that it's not just focused on women having to must doing this care. We need to be balanced because women are now in the workplace more. Quality assurance, coherence across policies and initiatives, but back to quality assurance, we know there's a lot of abuse in institutions, so we need to bring balance. So even within home-based care, so we need to balance that. Coordination of public and private care, regulation and professionalization. Professionalization usually is linked to discussions about training, formal training and certification of informal carers. So moving to the diamond of care, which is a key foundation to our policy solutions, programming, and so on, it must be a village. Just as with children, we say the village should raise a child, we need the village for care, especially as populations are aging. So just to go to some specific solutions, leave provision. Let's have some care leave, please, right? It's good that we have maternity leave and we have some areas, some countries or islands talking about paternity leave, but what about those of us who need care leave? A lot of us, in particular those who are childless and caring for older parents, we use our sick leave to care for older parents, and then we don't have sick leave to care for ourselves. So this is an important consideration. Care vouchers, as well as carer subsidies are some considerations and tend to be effective. Home care and support services, institutional care, as I mentioned earlier, respite care where persons can get a break from care and maybe a nurse or some other trained worker can come in and take care of the relative while they get a chance to rest and recreate. And we hear training mentioned continuously. So this brings me to the end of my presentation, and I look forward to hearing your questions. Thank you so much.
Thank you, Dr. Blake. Thank you, Hyacinth. And so you've left us off with an excellent segue. Let's do it. Let's get it done. So I think just to summarize 3 quick things before we go to the chat. And if anyone has questions, we have just about 6 minutes. Please raise your hand and we will arrange to speak with you. Just to summarize 3 quick things, I think that cross-cut all of our discussion today. One is the cultural context, right, and the importance of it. But the second thing is that there are similar patterns. There is this unequal gender division of labor that we keep reproducing, right, across geographies and across societies. And the third is the value of local knowledge in effective policy making, but also in changing and implementing policies. And I think these are like the 3 threads that have really cross-cut all of the presentations, and between the Caribbean and South Africa and the multicultural Caribbean, Trinidad and Tobago, Jamaica, Barbados, and the Western Cape in South Africa. So I have a comment on the chat. There are 2 comments. Ipeleng says powerful. This was for Ameeta and Fiona's presentation. And Glenda Rose is relating her experiences as well of caring for an aging relative with rheumatoid arthritis. And she also says that caring for the caregivers, right, is really important. And then I have another request from Mirel. Mirel says, could you please say out loud the following comments and questions, okay? Yes. To Ameeta and Fiona, Miguel Linares is a visitor at the University of the West Indies here in Trinidad and Tobago, a PhD candidate from Mexico, and would like to know about the qualitative techniques you use to collect the testimonies of the mother. So that would include the photo voice. And then the second part is, how do you guarantee that the interviewees and your co-researchers are safe from community's pressure or family members when they are participating? And she says, I am asking because, for example, in Mexico, some indigenous communities are really averse to different customs or foreign cultures. And so when my colleagues from the university go and speak with women for testimonies, they do not always want to participate in the research because mothers are scared or they are in danger of gender-based violence or domestic violence. And that threat of violence is always there if they try to organize collectively. So if we could ask Ameeta and Fiona to address that, please.
Is it okay, Fiona, if I take the first part and you take the second part? Okay, great. So thank you, Maria, so much for your question. So just in terms of the qualitative techniques, we use photo voice, but with photo voice, because it requires quite a bit of reflexivity, we spend a lot of time with the mums. In fact, at the beginning of each workshop where we meet with them, we redo exercises that associate objects or pictures with stories. So, for example, when we first met with them, we put out a whole lot of objects on the ground and asked them to pick an object to tell a story about how they are feeling, or to tell a story about what was winter like for them if, we just met shortly after the worst part of winter in Cape Town, or tell us a story using this object about, and we'd prompt them. We also got them, for example, as I mentioned, to draw their rivers of their motherhood, and that was seen as part of the data collection. We asked them to draw those concentric circles, and that was part of the data collection. We asked them to use magazines to tear out pictures of what their ideal motherhood could look like, and that they spoke to. And we had the photo voice. So the photo voice was around taking photographs back in their context and use that photograph to tell a story. And often we try to get them to use more abstraction in their photographs. So, for example, it didn't have to be of people. If they wanted to talk about that person, we asked them to think about what imagery could come to mind if that would make you think about something. So we spent a lot of time. We've got a fantastic lead methodologist, Jaga, who really speaks to the mums. And this project, we are in about 1 year and 8 months, or 1 year and 10 months of it. So I think that's important also to recognize that it isn't where we go in, get the data, get them to take photographs and sort of then move on. It's been a journey of building trust, of building safety. In fact, the mothers often come to us to tell us things or want to share with each other in the space. We have a WhatsApp group where they speak to each other. And the mums don't come from the same communities, which we found was a strength, because they wouldn't want to speak about these things in their very own communities because there are so many levels of judgment and shame. So they didn't, they felt that this was a space where they wouldn't be judged because back in the community, because there weren't other mothers from that community. And that was not intended initially. We wanted to get individuals from one geographical context so that we could intervene in that context potentially, but actually this was a surprising advantage of the project, that the mums don't come from the same communities. And And so, yes, so I think just to speak to the point about the qualitative techniques, and then getting the mums, you know, to first individually tell their story about one picture, and then inviting responses from the moms about that very same picture. And so we move from an individual level like of storytelling to a collective storytelling, then to an individual, from individual analysis to collective analysis. I hope that helps answer your question.
So can I pick up on the second part of that question then?
Yeah.
Question of safety is really, really important for us because we have unbelievably high rates of gender-based violence in South Africa. So we've approached this project really, really mindfully. It builds on very careful networks that Ameeta and some of the other partners have developed over time. These are not, the one partner is new, but some of the other partners are not new. And we partnered with a local civil society organization, Flourish, which supports mums. So it already had pre-existing relationships with mothers. There were already trusting, careful relationships in place through that NGO. And then we worked with the NGO. And this was very, very conscious as a means to ensure that we don't just swan in and do extractive research. The decolonial imperative for our research is really powerful. So we have built up over time long networks that we can then materialize these other networks through. That was the one component. The other is that we treat the mothers as experts. They earn a living wage to come to the workshops, just as we're paid to be experts in our domain. They are paid too. We provide childcare and we provide food for the workshops so that they can bring their children with, so they're not incurring debt on our behalf. The women have been very careful about who they tell about the processes that they're going through. They're very selective in who they tell. Some of them have told partners. Some of the partners came to the exhibition. Some of them have chosen not to. Some of them have been exposed to violence, not as a direct result of our project, but as a result of the way that people are made to live in this country. So of the incredible, somewhere else I've described it as raw life, the incredible rub of everyday life in people's networks. But we pay a lot of attention to this. We're very, very mindful about the kind of relationships that we set up, the forms of extraction that are typical in the research environment in South Africa, and the way we don't want to replicate those. Part of the process also involves iterative checkup. So we check in with the women regularly, and then at the beginning and end of each workshop period to make sure that people are as okay as we can facilitate for them. So I hope that also helps answer that question.
Thank you. Yes, thank you, Fiona and Ameeta. Yes, Mirel says thank you. Excellent. There's one question also for Bephyer and Hyacinth. And then I think we'll have to close off as well, because we've kindly been given a few additional minutes. And so Hyacinth, Dr. Parey and Dr. Blake, Mirel is also asking, in terms of this core idea of duty, of care as a duty, in your research in the Caribbean, have you also had some outcomes regarding behaviors to change women's role from that of primary caregiver to either the older population or the younger population? And so again, she gives an example from Mexico, where care is primarily women-centered, right? It's an expectation for women. And for middle-class women, there's still this expectation. She says, we must take care of our families if we decide to have our own, but also of our parents and our grandparents. So that idea of the sandwich generation is also still present. And so in spite of the working activities, Mirel continues, for incomes, family duties, and also the care of older persons, continues to be women's responsibility. Even in terms of medical interventions, our older population should have a responsible person for the medical procedure. What I can see is that current women or younger generations are not having as many children, and they are moving away from adhering to that expectation of caring. And she would like to know if you see a similar sort of pattern, whether through your research or anecdotally in the Caribbean. So, Bephyer, would you like to go, and then Hyacinth?
doctor. Unfortunately, I can't fully answer the question because my work is not specific to the care of children and specifically mothers, but in the context of research on social behavior and the taking of the carer roles for older persons with disabilities, I can't say that there is any, unfortunately, and I would say as yet, only because what you highlighted is a very important component, I think, that needs to occur. And I'm speaking from the context of someone who actually had a carer role for about 10 years. And I think what helps in changing the behaviors is education. I think a lot of us are not educated about these roles that we're taking up, and we think it's just something that we have to do and don't understand the implications of taking up these roles. So I do think that there is a need for more public education about this, and yes, some research to follow in terms of measuring the outcomes of that public education. So thank you for your question. Hyacinth, you're still free to add.
Yeah, sorry,
Well,
Hyacinth,
actually,
definitely. Yes, I just saw your message on the chat, but please go ahead.
no, that's fine. Morally, it's an excellent question, but it's definitely, there's need for more research on this. So I won't be able to speak to it based on the research I conducted, but I think Dr. Parey handled it well. And I hope that you, Morel, would be one of those persons exploring this further.
Thank you. And so one of the things Bephyer and I have also co-authored a policy brief for this year's Think 20 G20 Summit, which will be held next month in Rio de Janeiro. And next year, actually, South Africa. I'm sure Fiona and Ameeta, you know that, will hold the G20 presidency. And so there is some more scope for us to do this kind of transatlantic and transnational work. And one of the things that we raised is precisely this point about choice and agency. And so there's not, and everybody has raised that, there's not this one size fits all kind of solution to addressing this asymmetrical division of labor, right? And so I just wanted also to say that, and our policy brief is open access if anyone would like to read it. It's reducing women's vulnerabilities in the care economy, and we draw a lot from research in the Caribbean. We do have 1 minute. Is there anything that any of you as presenters you would like to ask or comment on? Final comments before we end. Okay, thank you. And I'm sure that everyone will be happy to communicate by email or messaging or on X and social media. So to end then our Centering Care in the Care Economy webinar today, thank you so very much for all of these presentations and all of these discussions. And Glenda Rose is also saying in the chat, thank you, it was very informative. I would also like to extend a special thanks to the Globalization, Accessibility, Innovation and Care Research Network out of Tilburg and Leiden universities that I belong to. And at the University of the West Indies, the Faculty of Social Sciences, the Department of Behavioral Sciences, SALISES, and the Disability Studies Research Cluster. And of course, at UCT, the Faculty of Commerce, the Faculty of Humanities, Department of Anthropology, and Management Studies and Organizational Psychology. So thank you very much, and I'll bring our session to a close today. Thank you, everyone. Bye-bye.
Thank you.
Bye.